హాయ్ పురుషోత్తం, నేను క్లాస్లో ఉన్న తర్వాత చేస్తాను. ఓకే. రైట్. Good evening, friends. We will start our discussion on CNS tuberculosis. Very important subject, and I would like to discuss briefly about the disease per se, the epidemiology, and we'll briefly learn about the various manifestations of neurotuberculosis. But I'll be stressing mostly on TB meningitis. We'll talk briefly about multi-drug resistant CNS tuberculosis and DOTS. The most important is the diagnostic criteria, how we come to a diagnosis when there is no gold standard test available to diagnose tubercular meningitis. As you know that 2000 million are infected every year by tuberculosis, and at least 2 million are at risk to develop tubercular meningitis out of the 200 million who are at risk for developing tuberculosis. This is a third leading cause of mortality sometime back in developing countries, and pediatric admissions to the hospital are about 2.5%, and 7 to 8% of adult admissions to hospital also are neurotuberculosis. HIV infection is a new body, was a new risk factor, means around since about 2000, the dawn of the century, and it's a risk factor. And if you look at the incidence rates, India has got about per 1 lakh population, you can see that there is about 100 to 299 cases are there, and in the tuberculosis estimates. And that means we have a large chunk of tuberculosis with us, and we have to next see the notification rates, and notification rates are more than 100 per 1 lakh population new and relapse TB cases. So out of these, as you see, that a percentage of them will have about 78% tubercular meningitis cases. And contributions to the global increase in the tuberculosis, if you see, India is contributing a large number of cases. So in India, tuberculosis is considered the most common disease. You can see how much we are contributing. Number of new smear positive cases in 2006 and 2007 is so much of percentage in the world. It's about almost 70% we are contributing to the world. That means our country has a large burden of tuberculosis. So, central nervous system tuberculosis can be classified into intracranial tuberculous meningitis with or without miliary tuberculosis, encephalopathy, vasculopathy, tuberculomas, tuberculous abscess, port spine and Pott's paraplegia, tuberculous arachnoiditis, non-osseous spinal tuberculoma, spinal meningitis. One point to know is that all tuberculous meningitis cases also have spinal meningitis. The meninges are continuous membranes which surround the brain and also extend to the spinal cord. So, if we don't treat tubercular meningitis properly, and they land up in tubercular arachnoiditis, which is a very difficult thing to treat. The most common presentation of CNS tuberculosis is tuberculous meningitis. It has protean manifestations, and often the diagnosis is missed. Many a case goes around the hospital with headache, neck pain, and not diagnosed with tubercular meningitis. As I said, the incidence in patients with tuberculosis is about 7 to 12% before the AIDS epidemic. And once AIDS epidemic started, there's a re-emergence of CNS tuberculosis, both with typical and atypical mycobacteria, and multi-drug resistant cases also started coming. The pathogenesis of is very interesting in tuberculosis. It is a dysregulated inflammatory reaction. Subpial or subependymal rich foci, and most commonly situated in the sylvian fissure. Now, one should note the sylvian fissure thing. They are commonly situated in basal systems or sylvian fissure. These are the rich foci. They developed during the initial bacteremia stage when tubercular bacillus enters the body. TBM develops after the release of bacilli from rich foci in communication with the meninges into the subarachnoid space or ventricular system, but not by direct hematogenous invasion by the acid-fast bacillus. So the rich foci, they rupture and release the bacilli. It's not that a open case of tuberculosis is there and then from there hematogenous spread. Hematogenous spread may occur, but it will take it's in less number of cases. So the pathogenesis, primary infection with Mycobacterium tuberculosis bacilli, hematogenous spread to the brain, rich foci, you can see him, rupture or growth of rich foci, various manifestations of CNS tuberculosis, and why they rupture and cause this we don't know really. So what happens? There is a perivascular demyelination, lot of white matter changes. There may be ependymitis because the bacilli are released into a ventricle because these are subependymal, and choroid plexitis. There will be tuberculomas and tubercular abscesses when coalescing caseating granulomas are seen, and thick exudates, they cause border zone encephalitis, vasculitis, infarctions, obstructive hydrocephalus, communicating hydrocephalus. So these are the various mechanisms of pathogenesis of tuberculosis. So you can see, look here, These are the bacteria, these are the neutrophils, monocytes, blood, and this is the brain. And this is the endothelial cells, and these are tight junctions, the microglial cell. So the bacilla has to come and activate the microglial cell so that the inflammatory cytokines are released. Uninfected cells and the infected cells. Diabetes of infected cells and infected microglial cells, cytokines are released. So the diabetes of uninfected cell also happens, disrupted endothelium and base membrane. This is the development of a rich focus with a cuff on the innate and specific B cells and T cells. These are the cytokines from the microglial cells. So the origin of tubercular meningitis is from the rich focus which was there since the childhood, and this is how the rupture with focus spread of infection into the meninges. This is the white matter, the gray matter, this is CSF parameter, and this is the arachnoid matter. So this is situated somewhere here, and it ruptures and causes the meningitis. So if you look at the briefly the pathogenesis and the spectrum, you see the HIV infection, pulmonary infection with Mycobacterium tuberculosis, and meningeal and subcortical rich focus, rupture of a rich focus, meningitis, increased bacillary replication in the CSF with increase in the CSF interleukin 8, TNF alpha, and interferon gamma, and they cause vasculitis, encephalitis, and meningitis, and there will be increase in neutrophils and lymphocytes. Now also increase in CSF lactate, CSF protein. There is a breakdown of blood-brain barrier and decrease in CSF glucose. The matrix metalloproteinases, which disrupt the blood-brain barrier, are increased in CSF, and coma, infarction, hydrocephalus, edema, increased intracranial pressure result. And so there will be two things: that time to treatment, drug resistance, and drug levels in CSF and HIV infection. Either the response is good, basal inflammation decreases, vasculitis decreases, and there is a good response to CSF glucose, which will improve with treatment, or complications take it up to cranial palsy, hemiparesis, death, or disability. So this is in brief the pathogenesis of the tubercular meningitis. Now, the molecular and cellular pathogenesis and role of TNF alpha is hotly debated, the main factor for host mediated destruction of infected tissue. CNF, CSF TNF alpha, it correlates with disease severity in pyogenic meningitis also, but its role in tubercular meningitis is rather confusing, and especially in, but people have targeted this, and they tried treatment with thalidomide and an anti-TNF alpha drug. It improved survival and neurological outcomes in rabbits, but when it was tried in humans, a controlled trial had to be stopped prematurely due to many adverse events. So really the pathogenesis and how the ultimately the destruction takes place remains a enigma for a long time. Headache is the most common symptom. Fever, headache is about 80%, fever is seen as 60 to 95%, vomiting 30 to 60%, photophobia 5 to 10%, anorexia 60 to 80. The neck stiffness can be seen in 40 to 80, confusion 10 to 30, coma 30 to 60%, cranial nerve palsies, hemiparesis, paraparesis, and seizures. So there's a confusion which can be seen in 10 to 30% cases, and that can confuse us also a bit. So this is a large study by Thwaites which shown the tubercular meningitis and bacterial meningitis comparisons, and finally which led to the score. And you see the male sex in this, and all these things were analyzed, and the hemiplegia is seen, because cranial nerve palsies are seen encountered. So after this large study, and which has got CSF analysis as well as others, the guy Thwaites from Thailand has brought out the. So in we also did a demographic 95 cases of tubercular meningitis uh, between 2016 to 19, and some of the features which we have seen are listed here. And there is no history of tuberculosis in 74% cases, and pulmonary tuberculosis only 12, disseminated in 4, and myelitis is in 1, miliary tuberculosis in 2, and types of comorbidities and retroviral disease in 14% cases, strokes were seen in 5. So in these are the age groups which we saw the cases, and you can see that 11 to the children are more susceptible. Up to 30 to 40 years got large number of cases. So this is our study, and prior history of tuberculosis, as said, is very less. So it can, we don't know when the rich focus has lodged in brain, and it causes so monto positivity, cranial palsy, this meningismus is in 53% cases. So in our headache, as I said, is the most common symptom in adults also, and apathy and behavioral changes are also seen in 30 to 70 cases, 70% of the cases. So these, the presentations are protean, though there is a clinical staging that has come into vogue. Stage 1 is up to 2 weeks, non-specific signs and symptoms, no clouding of consciousness or neurological deficits. Stage 2 is days to weeks, lengthy or alteration in behavior, meningeal irritation, sometimes cranial nerve palsies may be there. In the stage 3, abnormal movements, convulsion, stupor or coma, and severe neurological deficits. This is the stage 3 of the tubercular meningitis. So the modified British MRC severity grades: grade 1, alert and oriented without focal neurological deficit, and second is GCS 14 to 10 with or without focal deficit, and or GCS 15 with focal deficit. Glasgow Coma score less than 10 with or without focal neurological deficit is a modified British MRC severity grade 3. So this is the stage 2. You can see the tuberculomas, and there will be arthritis, and there will be vasculitic changes, and there are changes in the brain parenchyma. The tuberculomas can be seen. So the staging of our study: stage 1 is 40 cases, stage 2 is 27, and stage 3 is 28 cases in our cohort. The difficulties are because the non-specific clinical features, the paucibacillary stage in CSF, incompletely assessed diagnostic methods, and CSF forms the cornerstone, but we get often confused with the CSF first. So in our case, diagnosis of TBM, and early diagnosis could be in about say 66%, and delayed diagnosis is about 33.7, because if we delay the diagnosis, complications will be more. Professor Ahoja diagnostic criteria were published in Tuberculosis and Lung in 1994 from All India Institute of Medical Sciences, which are the first diagnostic criteria that have come in India. Because there is, whenever criteria are there, you can say that there is no gold standard test for this, and he based his criteria on clinical fever and headache lasting for more than 14 days, which is a mandatory criteria, vomiting, alteration of sensorium or focal deficits, pleocytosis with more than 20 cells, predominantly lymphocytes, protein greater than 100 milligrams, sugar less than 60% of the corresponding blood sugar, negative India ink studies, and cytology for malignant cells. CT studies of head showing two or more of the following: exudate in basal cisterns or Sylvian fissures. Just observe this. We had a case where we had problem in diagnosing because it was involving Sylvian fissure, hydrocephalus, infarcts, and gyral enhancement. So there are extraneural tuberculosis which you have to look for in lungs, GI tract, urogenital tract, lymph nodes, skeletal system, and skin, as evidenced by appropriate radiological or microbiological tests. So then you can categorize them into definite, highly probable, probable, and possible tuberculous meningitis. We have followed these criteria for a long time till we got the White's criteria also. So the key points are raised cell counts and proteins, and hypoglycemia, that is less than 60%, and AFB in CSF for culture, evidence of extraneural tuberculosis, and another point is response to anti-tuberculosis treatment. So you have to wait for at least 4 weeks for the response to be seen, 4 to 6 weeks. So then comes the Thwaites criteria, where age is more than 36 or less than 36 you see, and give points accordingly, 2 or 0. And peripheral WBC count, if it is more than 15,000 you give 4 points, and less than 15,000 you give 0 points. History of illness, more than 6 days or less than 6 days, minus 5 and 0. And WBC count in CSF more than 750, 3 points, and less than 750, 0 points. And if that count neutrophils are more than 90, it is 4 points, and less than 90, it is 0. The interpretation is, when you make this score, if it is more than 4, it is non-tuberculous. So some type of approach is always better for us, instead of no just saying that CSF has shown this and that's why it is tubercular meningitis. Now there's another scoring system, that is a Lancet scoring system, which has combined both the systems earlier, that is clinical criteria, CSF criteria, imaging criteria, and evidence of tuberculosis elsewhere. This is also in vogue, the Lancet scoring system. This means if we have so many systems, the understanding is that there is no gold standard and everybody can interpret a clinical scenario the way they like. But we have to have a clear cut suspicion that it could be tuberculous meningitis, and you should investigate further. The most important investigation of molecular diagnosis is PCR. Sensitivity is about 56% and specificity 98%. Relation to treatment before ATT, molecular diagnosis, bacteriology. After ATT, PCR is more useful. So recovery of AFB and CSF is only 25 to 45% cases, but it will be more if it is in HIV relation, or also you do a large CSF sample, about 10 ml centrifuge, and then look for it, then you may have culture positivity. In Indian studies, 85% of clinically suspected TBM were found to be PCR, and 61% of non-tuberculous controls also had PCR positivity, that means false positive rate. So PCR tests have got some limitations, and so the symptoms should be more than 6 days, optic atrophy, focal neurological deficits, abnormal movements, neutrophils less than 50% total CSF WBC count. So the sensitivity and specificity varies the number of features that are available. The methods of to increase mycobacterial yield on CSF smear examination is examine the deposit on a centrifugation of a 10 ml CSF sample, as I said. Examine the deposit for at least 30 minutes. Examine CSF samples for a few days. Repeated sampling increases Jaden stain sensitivity to more than 80%. The cell count is very, very important also, and the opening pressure may be raised, appearance will be clear, and neutrophils predominate in sometimes, and that is acute presentation of TBM, and lymphocytes predominate in 30 to 90%. The cell count is very important in CSF examination. You have to take these cells immediately after doing the CSF examination to the lab, sit with the technician under the newborn chamber, please count the cells and come back. The original report by the lab in charge will come later, but you have a fairly good idea because the cells get lysed if you don't do it immediately. This is what I request all the residents to follow in All India Institute of Medical Sciences, where I was trained. The first job, CSF is considered an emergency. You have to go to lab and get this done and come back quickly. Otherwise, you lose the very important examination finding of and cells. And cells also, you should do the fourth bottle in CSF. So when you start doing CSF, you please number the bottles 1, 2, 3, 4. 5 is to be kept in fridge for later use. Fourth should be sent for cytology. If you want to compare, you can compare first and fourth also. So hypoglycemia is important because many people don't do the blood sugar test at the same time. The moment you do CSF at the same time, you have to do blood glucose also. See that these are the two important things which I have to tell you. And the CSF analysis of another blood, in our cases the cells are median range 140, glucose is 47, protein is 133, adenosine deaminase, which is a marker of cell mediated immunity secreted by lymphocytes, is again 7.9. It varies between 5 to 15. If it is more than 15, it's indicative of a cell mediated immunity activation, but it can be seen in other diseases also. So it's not only specific for tubercular meningitis. The CSF studies, I am not going to go into the details because every one of you know how to differentiate from the bacterial meningitis to tubercular, viral, fungal, and neoplastic meningitis. Let us talk a bit about ADA. Higher levels in TBM than in viral, bacterial, malignant diseases. If value is more than 15 units per liter, it's a strong indication of TB meningitis. Limited utility in HIV associated CNS tuberculosis because the immunity as such is in a low ebb. So any reading, like we had a reading of 20 units per liter, is a strong indication of tubercular meningitis. The molecular assays are the talk of the day now. Gene expert is very often quoted. Whenever conventional bacteriological assays are insensitive, they are slow and expensive. There is the resort is made to Gene Expert, which is a commercial real-time PCR based assay for detection of Mycobacterium tuberculosis in clinical specimens and detects mutations associated with rifampicin resistance also. This was endorsed by WHO in 2010 and is being adopted globally as a frontline diagnostic test. There are three studies have investigated the role of Gene Expert in the diagnosis of TBM and found the assay to be around 60% sensitive, nearly 100% specific. That means if it is positive, no doubt this TBM is there. If it is negative, on 40% times, you may have to look for other evidences because that doesn't rule out tuberculosis. Testing of centrifuged CSF Centrifuged CSF from a large volume of CSF enhances sensitivity to almost about 80%. So we have to have a large sample, it has to be centrifuged. The WHO is recommended as an essential diagnostic test in people with suspected TBM, but the results must be interpreted with caution and it should be used as a rule in than a rule out test. A very highly sensitive test, if it is negative, rules out the disease. But our test is 60% sensitive, but it cannot rule out the disease. But it is 100% specific, so it rules in the disease. So if it is positive, we are lucky. If it is negative, we are not lucky. We keep fighting with one another whether it is diagnostically true or not. Further investigations searching for additional evidence of TBM should always be sought in such a situation, and anti-tubercular treatment should be started without microbiological proof in individuals clinically suspected of having TBM. A second generation gene expert test called Ultra is available that relies on the detection and amplification of a multi-copy gene target, and a 2017 WHO report suggested 95% sensitivity for TBM, and this test is available in Delhi, so samples have been sent to Delhi in some cases for getting the reports. So then there is some more lipoarabinomannan as a diagnostic marker in CSF, and this also has got more good sensitivity but not widely available. So I am not going to discuss about this much. Now the other thing is this interferon gamma assays, and the specific immune response. This interferon gamma is released from the T lymphocytes from the Mycobacterium tuberculosis infected individuals, and the 2016 systematic review and meta-analysis found that overall sensitivities of blood and CSF interferon gamma release assays were 78% and 77% respectively, with 61% and 88% specificity. So no test has got 100% sensitivity and specificity. If it is there, we are lucky, then we can adopt that test. But many tests have their limitations. So often we have to ask ourselves what is the sensitivity and specificity of the test, and the use of highly sensitive test is in ruling out the diagnosis. That means it has got more false positives. If such a high sensitive test is negative, we can say that disease is not there, as we do in cases of HIV infection, because we do a ELISA test, and if it is negative, we take it is not there. If it is positive, we go again and rule out the false positives by doing a Western blot test. So this test is moderate efficacy, and indeterminate results are in 50% of the cases. Then the radiological features of TBM, tuberculosis, the basal exudates, hydrocephalus, and see the thick exudates, tuberculomas, infarcts. So these are the various things which can happen in there is nothing specific. You can't go to a radiologist and ask, is it tuberculosis, is it CNS tuberculosis, is it TBM? These are all non-specific findings. They can only help us in understanding the disease. Yes, if you see the exudates, thick exudates like this, you can still think, and tuberculosis will help. So there is, we cannot conclusively say that we can, but you have see the basal exudates are very important to diagnose the tuberculosis meningitis cases. The CT is shown here. The CT with contrast, you can see the exudates. A meningeal enhancement in all systems and over the convexity of the brain in all patients. But remember, they are in basal systems and Sylvian fissure. 65% had tuberculosis and 77% of those with cranial palsy showed contrast enhancement with or without thickening of the involved nerve. The MRI was done in 20 patients and revealed focal arterial narrowing at the terminal segment of the internal carotid artery and proximal segments of the middle and anterior cerebral artery, which will give rise to infarcts. So you can see paradoxical increase and appearance of new lesions on different sites while the patient shows improvement on ATT answer. So this is the initial 2000 MRI, CT scan, and after ATT in December 2000, the MRI has shown improvement, and but 2001, he had to undergo surgery because of the tuberculosis, and decompression has to be done, and new lesions have started in 2001. Long, you can see the there is disappearance, but it took such a long time. So the treatment, at times my maximum duration I gave is about 3.5 years in a particular case. The appearance of new lesions while on ATT is a known fact, and you can see while patients are taking treatment also the tuberculosis. So it is a very difficult disease to treat. 50% of tuberculosis meningitis cases die, and the diagnosis is often delayed very much. The management issues, and how long you have to give ATT, biopsy if required when, role of steroids, role of surgery. So these are the any other options available. These are the management issues which we should do, and this is the MRI T2 weighted image and gadolinium enhanced. You can see the granulomas seen, and any granuloma, any lesion infratentorial region is treated as tuberculoma, whether you suspect glioma or anything, but a trial of anti-tubercular treatment is always given in infratentorial solitary lesions. Gadolinium enhanced lesion, and you can have a spinal cord problems, and you can see the spinal cord tuberculomas in some of our cases which we saw, and you can see the myelitis picture, myelitis which mimics as if it is NMOSD. So neurological imaging features of our cases: hydrocephalus, basal meningeal enhancement, tuberculosis, infarcts, pre-contrast basal hyperintensity, which is an important finding, and normal MRI in 26 cases. So these are our own findings, and what I showed earlier, what's available in the literature. So what are the advances in neuroimaging? Contrast MRI with FLAIR, best for CNS tuberculosis. To differentiate pyogenic abscess from tubercular abscess, the MRS, magnetic transfer imaging, MR imaging, and MRS are seen. Prominent lipid peaks are MRS findings, high lactate, no amino acid preference. These are important issues in the neuroimaging. The differential diagnosis is always extensive. You have to differentiate from partially treated bacterial meningitis, cryptococcal meningitis, viral meningoencephalitis, carcinomatous meningitis, parameningeal infections which will give rise to cellularity in CSF, neurosarcoidosis, neurosyphilis. That's why the origin, the history is very important. This is how long the problem is there, and the initial laboratory findings are very important. The complications are raised intracranial pressure, cerebral edema, stupor, basal meningitis with cranial nerve palsies, focal neurological deficits, hydrocephalus, tuberculosis, abscesses, optochiasmatic pachymeningitis resulting in visual loss. So I'm afraid of giving, to tell you the truth, ethambutol, and I have seen many cases losing their vision with ethambutol. So, though a bit painful, I always prefer to give SHRZ than EHRZ for my cases. The complications, as I said, arthritis and stroke, endocrine disturbances. There is involvement of pituitary gland also suspected. And hyponatremia is a common occurrence. It could be because of cerebral salt wasting or the disturbance of pituitary function, hypothalamic disorder leading to a loss of control of BP and body temperature, diabetes insipidus, SIDH, internuclear ophthalmoplegia, hemichoria, and Efroin syndrome with spinal block, spinal arachnoiditis. These are the other things which you may have Addison's disease also with low blood pressure and involvement of adrenal gland. Commonest complication is hyponatremia. Said 50% of the cases have this. So in fact, what I do is I always give 5 grams of salt both morning and evening whenever I start the anti-tubercular treatment. It could be because of salt wasting attributed to renal tubular defect, hyponatremic natriuretic syndrome attributed to plasma natriuretic peptide, and SADH. So whatever it is, we have to attend to hyponatremia. The sequelae are psychological, psychiatric disturbances, visual defects, hearing defects, focal neurological deficits, endocrine disturbances, seizures, intracranial calcifications. There are many of them. The HIV co-infection does not alter the clinical presentation of TBM, affects the number and nature of the complications. Basal meningeal enhancement and hydrocephalus are less common because the inflammatory reaction secondary to immune crisis is less. More bacilli on the meninges, increased case fatality, increased CS of yield of AFB positive organisms. Active extrameningeal tuberculosis is more common, so are polymicrobial infections. So we have studied neuro AIDS and about 57 cases of neuro AIDS. After death, we have done needle necropsy by putting a long needle in the suboccipital region into the brain and take a smear and also inoculate into the media. What we diagnosed was in cases acute pyogenic meningitis into CNS tuberculosis in about 55 cases, TBM 40, TBM plus microbial in 2, TBM plus cryptococcal in 3, TBM plus candida in 1, tuberculoma 7, spinal TB1. This is the bacterial infections of neuro AIDS, that means polymicrobial infections, and it's common to have a combination of cryptococcal meningitis with TBM, cryptococcal meningitis, candida, and TBM, etc. in this. So the AIDS picture is very dangerous. Extrapulmonary tuberculosis is AIDS defining illness since 87, and active tuberculosis is more common in HIV positive individuals. Extrapulmonary tuberculosis is also more common. It is TBM meningitis is a AIDS defining illness in more than three quarters of HIV infected individuals. In our case, as I said, pure TBM is seen in 40 cases. I'll show you a couple of slides. The differentiating features, as we saw, are the protein and cells. Cells are always less in cryptococcal meningitis. You see, antemortem CSF, we have 10 cases of AFB positivity, and similarly we have cryptococcal and the India ink positivity also is seen in a large number of cases, about 22. So this is very important for us to see that chronic meningitis CSF work is very important, and these are one of some of the our cases which of neural, and you can see the cryptococcal, the candida and the AFB in the same smear which we done, and these are our radiology cases which are showing multiple granulomas in right, and we have done the MRS in these cases with a lipid peak, and which you can see in this particular picture. Lipid peak rise in choline and creatinine ratio also can be seen. So this combination is characteristic of tuberculomas, and you can see this is the choline, this is the creatine, this is NAA peaks. This is a normal picture, and tuberculoma, you can see there is a choline and creatine peak which is high, as well as the lipid peak. So these are the MRS findings of tuberculoma for the students to learn. Okay, so these are the cases, and you can see the choline and creatine peak and lipid peak in the tuberculoma which is shown in this case. So complications in our TBM cases, about 51, the no complications are seen in 53%, hyponatremia in 9, hydrocephalus in 11%, stroke in 4, epileptic seizure, tuberculosis in 11%, ethambutol induced optic neuritis in 1, rifampicin induced fever, and ATT induced hepatitis in 6% cases. So these are the things which we have seen on ground. The tuberculous abscess, tuberculomas, caseating granulomas of epithelioid cells and macrophages, they contain mycobacteria. They are single or multiple focal lesions, may develop during several years after ATT for TBM. For tubercular lesions elsewhere in the body also can trigger a tuberculoma formation. This is infrequently caseating necrosis occurs in tuberculoma, forming a tuberculous abscess that can present as a space occupying lesion with increased intracranial pressure, papilledema, seizures, headache, and vomitings, all the features characteristic of a raised ricep. The spinal involvement, as I said, epidural compression of the thoracic cord from vertebral and disc destruction by caseating granulomas is tuberculous osteomyelitis. As I said, all cases of tubercular meningitis also have involvement of meninges in the spine, but characteristically, we encounter lots of spinal tuberculosis alone, and, in the form of Pott's disease in one-fourth of these cases. The fusiform paravertebral abscess or psoas abscess and gibbous formation are more common. Extradural cord tuberculomas cause more than 60% cases of non-osseous paraplegia. Tuberculous radiculomyelitis may accompany TBM, subacute paraparesis with radicular pain and bladder dysfunction. So, examination of the lower limbs in all cases of tubercular meningitis, the reflexes, and to look for radiculomyelitis is an important examination clinical assessment finding in. So what, and the treatment now, we before the treatment principles is that INH kills rapidly replicating bacteria in first 2 weeks of treatment. Rifampicin kills low or non-replicating bacteria. Pyrazinamide kills those inside the hostile to the penetration, and streptomycin poor penetration of blood-brain barrier. So these are the principles of anti-tubercular treatment which I highlighted here, and the treat four drugs in intensive phase and HR for about 9 to 12 months. And this is the British Thoracic Society guidelines which are here for the anti-tubercular treatment, which we give about uh, say we can give up to 9 to 12 months, and these are the drugs which are recommended: isoniazid, rifampicin, pyrazinamide, ethambutol, acetaminophen. And one of the things which is important is that we should measure the body weight and give appropriate treatment, which is not done. The reserve drugs are the cycloserine, ethionamide, and other drugs can be done. Those steroids have been studied. Corticosteroids improve survival across all grades of severity. The dexamethasone for treatment of tubercular meningitis in adults, an original article is published, and all patients with TB meningitis, not HIV positive, should receive steroids, and we follow the Thwaites protocol, which I'm going to show in the next slides. Dexamethasone to be preferred over prednisolone in treatment of these cases. And this is the Thwaites protocol which I follow: zero point 0.3, zero point 0.2, zero point 0.1, and reducing by 1 milligram each week. Dexamethasone week 1, week 2, week 3, week 4, and you can adopt any of these. Thwaites et al. Grade 2 and grade 3 protocol starts with zero point 0.4, grade 1 protocol starts with zero point 0.3, and so totally whenever there is a requirement you can give intravenous and then switch over to oral treatment as shown in by. Uh, so this, we have some guidelines for use of steroids in tubercular meningitis. In India also, there is RCT of 41 patients randomly allocated to steroids and non-steroid groups by Dr. Kumar Velu and Prasad, and all patients received a standardized ATT regime. The endpoint was 3 months MRS or death, whichever is earlier. The evaluation at the endpoint included survival and uh, sequelae and activities of daily living. Uh, Patients in dexamethasone group fared much better than the other group. Intrathecal hyaluronidase is used whenever you have arachnoiditis. In addition to anti-tubercular therapy and steroids, it was found to be effective. in the management of spinal arachnoiditis by Dr. Gauri Devi et al. And so, a role of surgery, hydrocephalus, we need to do VA and ventriculoperitoneal shunts. Or the problem with surgery in tubercular meningitis is the protein should be lower than 100 milligrams. Otherwise, the VP shunt will get blocked. So you have to treat aggressively, bring down the protein, CS of protein, then only can look for hydrocephalus cure by VP shunt. Selected cases of tuberculomas and tuberculous brain abscesses can be subjected to surgery, and the adverse prognostic factors are altered sensorium, seizures, extremes of age, and high CSF protein concentration. The resistance to one or more first line anti-tubercular drugs is seen nowadays, and that results in a very poor outcome. Resistance to isoniazid is very fairly common, and so delayed stages of sterility. So we have to treat with a prolonged regime that includes pyrazinamide. In fact, we started treating with pyrazinamide for more than about 9 months in our cases of tubercular meningitis. Multi-drug resistant TBM, past history of treatment with ATT, if it is there, you suspect. There is a recent exposure to a known case of multi-drug resistant pulmonary tuberculosis. You suspect multi-drug resistant TBM. The PCR assay detects mutation in the mitochondrial tuberculosis, that is the gene expert, and role in pulmonary tuberculosis is well established, but in TBM it is so far unknown, this method of detection. Never add a single drug to a failing regime. That's a dictum. Use at least 3 previously unused drugs, one of which should be a fluoroquinolone whenever you suspect multi-drug resistant treatment. Other drugs include amikacin, kanamycin, ethionamide, and cycloserine. Of all these, I have used ethionamide with a fluoroquinolone. Duration of treatment should be for at least 18 months whenever you suspect multi-drug resistant tuberculosis. So for resistance, the initial phase and the continuous phase are given here. Resistant to isoniazid, you do rifampicin, aminoglycoside, pyrazinamide, ethambutol. Duration is 3 months, and continuation phase for this rifampicin and ethambutol 6 months. And if you have isoniazid and ethambutol resistant to streptomycin also, then you have to have pyrazinamide ethionamide combination, and ethionamide has to continue for 6 months. In the initial days of my physician job in 86 and to 90, I used ethionamide in anti-tubercular treatment in those days. So that's important. The conclusion is tubercular meningitis are protein manifestations. There is considerable morbidity and mortality. There are newer diagnostic modalities which will fascinate us, which we resort to, but one should always interpretation of diagnostic tests is based on sensitivity of the test and specificity, the positive predictive value, negative predictive value. There are many unanswered questions. Diagnostic modalities, what is the optimal regime? Still, we keep on fighting with tubercular meningitis. And in preparation of this lecture, I have gone into various references of epidemiology, pathogenesis, and of course the clinical features and presentation treatments and various other things. Tuberculosis central nervous system in children, and various reviews have been studied for the clinical features and presentations, and treatments also we have studied. Diagnosis tests have been studied extensively to prepare this lecture, and the treatment modalities have been reviewed comprehensively. And this lecture has comprehensively dealt with all aspects of tubercular meningitis as it stands today. I think with this, I complete the lecture, and if there are any questions, I can answer them, and we can have a discussion, and you can unmute yourself and ask questions. Yes, all have been unmuted. So please ask any questions or any clarifications. I hope it's clear to everybody. Uh,
Hello.
Hi, Dr. Jignesh, bolo.
Good evening, sir. Good evening, sir. Thank you, sir,
Good
for
evening.
this presentation. There
Uh,
are many learning points. The Lancet, I think, is very comprehensive score,
yeah,
which looks at clinical, CSF, and imaging.
that's correct.
And at times there are imaging. If the patient, as you said, if the patient presents to us in second or third stage, it is easier to diagnose. Basically,
Uh,
because we are going to have clear-cut imaging,
yeah,
uh, imaging features like
yes.
exudates or other
Uh,
features.
Yeah,
Yeah.
that's true.
I just wanted to know, sir, how is the vasculitis component correlated with the severity? Like, do you expect vasculitis only in presence of exudates and other features, or you can still have infarcts and don't have significant exudates or hydrocephalus?
That's correct. We may not have all the exudates. Stage 2 disease is characterized by vasculitis because it's a transmural inflammation of the blood vessels. So vasculitis can be inside the vessel or outside the vessel. So you can have infarcts without exudates.
Okay, sir. And the second thing is, sir, like because we have now CSA biofare which is available. Yeah, it does not checks for tuberculosis, but can we, if possible, if the relatives are affording, get a CSA biofare to just have a rule out diagnosis? Like other things are not there, so TBM is a likely possibility, or you will still consider clinical criteria and go ahead with AKT?
See, the problem with diagnostic test, it has to be highly sensitive test to rule out. If the test has got 99% sensitivity, I will say that if that test is negative, I will take that TBM is not there. Okay.
No, sir,
So
I'm talking about biofire. Biofire will test for other spectrum of viruses.
that is for
Yeah,
differential
the other
diagnosis, no?
viruses,
Yeah.
bacteria, yeah, other differential diagnosis.
Yeah.
So if it is possible, I think we have for this patient for of ours, na, we have
Yeah.
asked you, and the biofire test cost something around 11,000 rupees. Apparently,
Yeah.
the relatives are not willing or keen to send that for biofire. But if in case in future, if relatives are willing, can we just
Yeah,
also
florid
send the biofire?
encephalitis syndrome, we can do that test, but tubercular meningitis is not diagnosed in that fashion.
Okay. No, I
Yeah.
was just wondering whether we can use biofare as a rule out test. So, we have ruled out viruses, so it is likely to be tubercular then in early stages when the diagnostic criteria are not very clear cut.
Mm. Yeah, Ben, we can see it is depends on the clinical situation and what we are looking at
Yeah.
it. We cannot have a no blanket sanction ki ye sab ka hone se ho jata hai, but case to case we can use it.
And so we do badly struggle for the CSS cell count. Unfortunately, as a part of our training, we are never trained to identify those cells under the microscope. Yeah, in the Newberg chamber.
Today I went to the pathology HOD in the lab. I showed my residents. I requested that every time a CSF is done, my resident will come and sit with the technician under Newbar chamber. They will learn to identify cells and count. She has
Yeah,
agreed. She
because
has
now what
agreed.
if, yeah, because what has happened is, sir, we, not for this case, for in general also we struggle badly for
Hmm.
getting the cell count reports. They are not validated till next day morning, till a senior pathologist comes and reviews the reports. And often then this diagnostic dilemma is tried, and
Yes, I agree with you.
it's yeah.
I
And the
agree with you
second thing
because
is, second
uh,
thing was now, if you are considering vasculitis as a differential, if you have
hmm.
small infarcts, or so can we go ahead and do an MR angio also?
The MR angio will show again small narrowings in the vessel, small vessels. See, MR angio may not pick up the distalmost vessels.
Distal
It
most
will
vessels.
it will pick up medium size and large vessels. So
Okay.
it may not be very no, helpful to us.
Okay. And for this case, na, sir, the first time spectroscopy was not done. The MRI was
In
done
the
with a
spectroscopy is useful whenever you have tuberculomas.
yeah. So I think now we should probably, as a learning point, na,
Hmm.
if we are planning for an MR, we should request radiologists to get a spectroscopy also.
If there is a tuberculoma,
Yeah.
but it
We
won't be
in this
chiral
case,
enhancement.
yeah.
It will not come. Chiral
Okay.
enhancement, it will not come. The chiral
Okay.
enhancement has got no necrosis.
Okay.
It is not come. If you got a tuberculoma, it will definitely come. We have published a paper in Annals of Radiology in HIV with differentiation from cerebral toxoplasmosis also based on that. But
Okay, sir.
you will get it if you have tuberculosis.
Okay, sir. Um, Anybody else is having any
Anybody?
question?
Sir, sir
Uh,
Prashant
yeah,
here.
yeah, Prashant.
So you said if there are high proteins, it is not advisable to put on a BP
Yeah,
shunt. So
yeah.
in that scenarios, depending upon the clinical situation, should we
Hmm.
continue AKT and wait for the clinical improvement
Yeah,
or
actually, that
CSF
was
improvement rather?
my. Yeah, that's correct. My teaching from Allen Institute is that you have to go with steroids and anti-tubercular treatment and wait till the protein comes down.
Protein comes down,
Yeah.
and
Then you
will
have to.
it be like protein from the lumbar puncture or ventriculotomy?
No, it is a lumbar puncture
Okay.
because meninges are there. Meninges are
Yeah.
all around the brain and spinal cord, and ventricles. It's not the reflective of meningitis truly.
Okay.
Okay. Yeah. Any more questions?
Jain sir, this is Sengupta.
Hi, Shane. How are you?
Sir, fine, sir. Just firstly, just wanted
Yes.
to thank you. It felt so nice to be back in your class again.
Oh, thank you, Shane. HOD neurosurgery of Command Hospital. Ah, but do you think anything do you want to contribute anything? You want to say something?
Nothing, sir. Nothing great. Only thing was
Mm,
there are cases in which the MRI pictures it
mm.
becomes static after some time.
Okay.
Is there any point or any indication for which we should continue with the ATT for a longer duration than what is recommended in regular? I
See,
mean, in regular
that's
cases.
saying actually it's unfortunate that we don't have any recommendation. As I said in my talk, I have continued in one of our medical graduates for 3 years. She's doing quite well. Radiologically, tuberculosis are not going. So how long you give? I stopped, and nothing happened to that lady another next 3 years because fortunately we can follow this. So I don't really have an answer for it. I tried, and nowhere it is written.
Thank you so much, sir. Thank you, sir.
Okay.
Jai Hind, sir.
Okay, then, if there are no more questions, I thank everybody for their participation, and I'm happy that I'll close the. Okay, thank you, everybody. Good
Thank
night.
you, sir.
Thank
Thank
you.
you. Good night, sir.
Good night. Good night.